So thank you very much, Brendan. I'm thankful for the award and humbled a bit. This was certainly a bit of a surprise, but I'm very grateful. And I'll reflect in a moment about the intersection between what I've been working on and Frank Fenner's legacy, because I think they are very relevant. Always a bad move to correct your boss, isn't it? But measles did come back in PNG a couple of years ago. But it was really because they moved away from the decentralised approach to measles campaigns that we'd introduced back in 2003. With that approach, they did have 7 or 8 years free of measles, going from 300 deaths a year down to 0. But the sad thing is that people get fatigued with certain approaches, and the fatigue with the campaign approach has meant it's come back, which is really the sort of thing that I want to talk about in this lecture. I've got 3 points. Why it's important to research implementation, one of those I words, and I'm going to go back in time just very briefly to give 3 formative examples from our development work that helped bring us, and myself particularly, to this point. I'm going to spend a little bit of time just to show where the knowledge domain of implementation research sits as it applies to low and middle income countries. And then I've got 3 examples from our current research that illustrate this. But for those of you who need to check email or switch off in other ways, I'll give you the answers right now. So, why it's important: implementation research bridges the gap between what we know and what we should do. Implementation research for me can really be a key way to improve service delivery for mothers and babies, which is our focus, but it could be service delivery for any other health theme. And this is especially true if we focus on that engagement, the transaction between the client and the frontline health services, and my passion, which you'll hear about, for integrated healthcare services. But I want to go back in time to my very first encounter with Burnett. It was roughly this time of year in 1997 in a tuk-tuk in Kathmandu. And we were just looking at moving from 5 years of workers in Nepal to a strange new project in Tibet. And I was meeting a Burnet person for the first time. Never heard of them before, but this guy Damien in the back of the tuk-tuk was talking to me about a hepatitis research program they had in the Kathmandu Valley. Was talking about the Burnet model, where you bring expertise from Melbourne and bring it to these countries. And I was thinking, this is a bit weird, but at least they have a agreeably thrifty approach to transport in Kathmandu. So just to put the background in context, I've got 8 photos, but only 4 slides, of my history journeying from Sydney to Melbourne. So we went the long way round. I started in this converted shoe factory in the centre of Sydney, a suburb called Camperdown that was called the Royal Alexandra Hospital for Children. Finished my paediatric training there. And along the way met Alison Morgan. We had 1 shift together in emergency, and that was enough. But had always had this sense of training of wanting to be a doctor somewhere where there aren't many doctors. And that had built my, formation both as a paediatrician and as a doctor more generally. We did some tropical paediatrics along the way. And it was in 93 that we packed up the family, that was 2 children at that point, and went to work in a mission hospital in the Western Hills of Nepal, a town called Tansen. And quickly realised that sitting in the very busy paediatric outpatients, seeing what came in the door, was only scratching the tip of the iceberg, and that one needed also to get out into the villages to work on preventive care, community care, not just healthcare, work on women's literacy, water and sanitation, even animal health. All of those things go into making a healthier community. So those 5 years in Nepal really formed that sense of primary healthcare and integrated health as as a way to go. And I realised that the training program in Sydney teaching hospitals really had very little motorbike maintenance or any of the other skills one needed to actually get out into rural villages. And that brought me to 97, which is when we first met Burnett and joined the Tibet Primary Healthcare and Water Supply Project, which was a joint activity by the Australian Red Cross and the Burnet Institute, funded by the Australian government, that ran for 3.5 years in these remote villages in Tibet. We were basically doing two things: building health clinics and building drinking water systems. If anybody doesn't know about the Back Happy Tap Stand on the right, come and talk to me afterwards, but I think you've all heard that story. And it was at the end of the time in Tibet that we got enticed to come to this strange city called Melbourne, work at the Burnet Institute, and that was 2001, and I've been here ever since. And it's really the work at Burnet that got me interested and engaged in Papua New Guinea. So my first trip was as a child health immunisation advisor up in Port Moresby in 2001, and I've been going back many times a year ever since. And really in all of this, I blame Peter Deutschmann, who's sitting up there, because when he was working at the Burnet Institute around about 97, he was the one that talked us into making that big move to Tibet. And Peter's been a mentor ever since, and I'll acknowledge him shortly later. So, to get into it, that's the background. Implementation matters. So I was sitting in this room, this is the executive boardroom in WHO. One of my jobs since 2011 has been working on the Immunisation Practices Advisory Committee, one of those advisory committees in Geneva. And I was thinking about Frank Fenner, because I think it was a room very like this one, if it wasn't this one, where as the chair of the global group to certify the eradication of smallpox, he put his signature on this certificate. And it is still one of the most amazing, as Brendan said, one of the most amazing achievements of the human race, really, that we have got rid of a horrible disease from the face of the earth. We've done it again, although it's not talked about very much, but within the last year or so, we've got rid of the second strain of wild poliovirus that's now declared eradicated. And we are doing it with measles. Measles is now gone from the Americas region, from North and South America. There is no more wild measles there. So these things are achievable. And apart from integrated healthcare services, I really am passionate about immunisation, vaccines as a way to achieve this. And the fact that Burnet is working on newer vaccines to do this for other diseases, I think is a great part of our, what will be our legacy. So, sitting in this meeting, it's the Strategic Advisory Group of Experts. It's the group that comes together every 6 months, looks at global vaccine policy. What are the new vaccines? Are they safe enough? Are they effective enough to be deployed? Is there enough evidence to make a global recommendation that all countries should do this? And I'm sitting in my chair, and the chair Alejandro of the SAGE is on the opposite side. You can see him there sort of paying attention. And he brings up the issue of the birth dose of hepatitis B vaccine. And he says, it really frustrates me. We've made the policy recommendation, we've looked at the evidence, we've said to every country you need to implement, and it's just not happening. The evidence is there, the research is finished. Why aren't they doing it? And I put my hand up and said just 2 words in answer. And those 2 words were delivery science. And I think it's because implementing is also a big part of the problem. Implementation makes a big difference. And implementation, as you'll see, is a really fit subject for our research. It's been researched in Australia for a long time, but it's beginning to be researched formally within low and middle income countries. So let's take a quick thought experiment. Say we've got a vaccine against a particular disease burden, and this standard 2-dose vaccine is 90% effective in preventing the disease. So we get the vaccine out there, as the chair of SAGE said we should be doing, and we've only got this much disease left to worry about. fair enough, it seems. And that's really what he expected. We get hepatitis B birth dose vaccine out there, and then we can stop worrying about it and we can get other things onto the agenda of the meeting. But if we think of the obvious fact that you don't always get the coverage that you want, and you may not actually reach all the children that you need to reach, or all of the adults that you need to reach with the vaccine. So a little bit of a lower coverage, so I've put that at 80%, which is where world immunisation is currently sitting, means that you've got a bit bigger disease burden to worry about. And then if the vaccine has to be kept in the fridge, isn't kept in the fridge, so it becomes a bit less potent, it's the quality of the management of the vaccine or the service is such that it doesn't actually work as well as it should, we get another drop. And then perhaps the families are not coming back for the second dose, so we don't get the full immune function the vaccine can produce. So instead of the small amount of effectiveness against the disease burden, the implementation phase can drop what we can achieve by a significant amount. This is not a new idea. I've got up here a picture from a 1978 paper by a WHO employee called Tanahashi, who was making exactly this point, that you were trying to get to the whole of your target population, but the availability, as in just getting the commodity out there, may be low. The getting people to the clinics where it's available, maybe another drop-off. People may not actually want the service as much as you think they should have it. And so on, until your effective coverage, which includes getting a good quality service, is significantly lower than your target population. And so this is all about the problem of implementation. This really matters. So I've got one example from the WHO Implementation Research in Health Guide that came out just the year before last. And the example is from maternal to child transmission of HIV in Zambia, where you can see that you've got, if you've got maybe 14,000 pregnant women who are tested, but then there's a big dropout in the number who are checked for their CD4 count to see if they need treatment or not. Then there's those who actually get their results and those who are found eligible. There is a major decline in the implementation cascade. So we've got something we know works, we've got something that's been proven by research to work, but it's implementing that is the big problem and gives you the gap between those who should receive and those who do receive. So, 3 quick examples of how we've got to where we are now in terms of thinking through researching implementation. The Tibet Health Sector Support Program, which was the follow-on from some of the earlier work in Tibet, one of the key streams of work we set up was what looked like a quasi-grants program where we would invite health managers to think with a little bit of guidance on management theory, a little bit of guidance on capacity development theory, what they wanted to change in their hospital or their public health institute. They would bring their own proposals, and then we would help turn those proposals into an operational research activity and then work with them to actually implement a change and measure the change. So it sounds like ordinary development, but it's actually applying a research spin to the way that you put it into practice. We saw one hospital totally transform its management capacity in Shannon through taking this step-by-step process. We saw another director of a maternal and child health hospital for the first time do a client survey and understand what things meant from the client's point of view. And these same messages around the importance of a research approach to achieving a development outcome were picked up in the later Tibet activity, the one that is closing up just this year that Robert will be heading off to. And it gives me a chance to give a shout out to Tony Lai. So when we first went to, Tony's there looking at a graduate's new certificate of competency that has been provided by the government on a program that he helped set up under Tibet Health. So Tony is, one of the joys about this job is the people you meet along the way. Tony is one of those joys. He was teaching himself English while sitting on the hillsides in near Shining, looking after his parents' sheep. and managed to get through a Bachelor of English at the Xining University. And then he ended up as the executive assistant to the manager of a Nike factory in Guangdong. This was in the 90s. And he was pretty sick of that. He wanted to work for an international group. So he cold called me when I was sitting in Tibet, desperate for staff, and said, "Hey, have you got any jobs?" I was so desperate for anyone who could make sense in English, and he made sense in English over the phone, that we offered him the job. He came to be our office manager in the Shigatse project in 98. He stayed for the whole 3 years. He then came down, did a little bit of training in the Burnet subjects for 6 months after we finished the Shigatse project. Went back, got a UK scholarship, learned some health management, worked as a management advisor on the THSSP project, got in with a good health economist in Beijing, did a PhD in health economics using some of this data, and has now been, for 5 years, I think, Robert, the team lead. Yeah, 7 years. The team leader, so the boss of our Tibet program.
First author on 39 papers in the last 3 years.
So first author on 39 papers in the last little while. So these are the sorts of people that make a difference. And what I really admire is this sustained commitment Tony has made to the health of Tibet. And we've seen some amazing achievements from that. I'm not going to spend as much time on the next two examples, but I did want to mention Tony. We were very much hoping he would be here in November. He would be able to do one of presentation to you all, but the Australian government in their wisdom didn't approve the travel. We'll try again next year. So, also in China, we were given $35 million to help reform the Chinese health system. And this was the very first Australian aid project with the Chinese Ministry of Health. And when you talk to the Chinese Ministry of Health in the middle 2000s, they were saying, well, we're spending about $1.2 billion US dollars on the reform of our health system. So thank you very much. Come and join the party. But we're really searching for how to make the Australian investment really make a difference when it was this much in a sea of this much. And the way was to focus on policy and health systems research. And the sequence is crucial in that we would work with senior technical advisors in the Ministry of Health. So what are the questions really important to you? Then we would invite a Chinese, not an Australian, but a Chinese agency to turn that policy question into a research question, and which usually took about 3 months. And then if they could come up with something worth looking at, we would then fund that particular activity, and along the way get the Chinese institution linked to an Australian partner. So you can see it was Chinese-led, but it was focused not on a development outcome using development language, it was focused on a policy or a health systems research outcome. We got 53 initiatives funded. There's demonstrable contribution to quite a large number of policies, 120 publications in Chinese journals and 10 in international journals, which is a very unusual product for a development activity. So the last example is our ECPIC study, again from about the same era, of training lay health workers, that is village health volunteers, who don't normally get allowed to do vaccination, but because there was this appropriate technology called Uniject that was suitable for volunteers to do vaccination with, we were able to get an exemption and try training these volunteers as vaccinators just for hepatitis B. And hepatitis B is important because it's the only vaccine that has a critical time window to get it to the child, a really critical time window. So if you have a mum who's infected with hepatitis B and she's quite infective, then she's got a 90% chance of passing that on to her baby. But if you get a vaccine, the Hep B vaccine, within 24 hours into that baby, you can interrupt that perinatal transmission and drop that 90% chance to less than 10%. But it's got to be within 24 hours, and that's the global recommendation that SAGE were getting excited about not being implemented sufficiently. Problem is, how do you reach babies within 24 hours when they're born outside the health centre? This was one way to try and do that. And the project was essentially operational research to show that it's feasible and acceptable to do it this way. And what it showed us is that this is good to do, But as an institute, and me personally, we actually need to build a repertoire of tools to do this implementation research in a more rigorous fashion. It's easy enough to make it up as you go along, but we actually need to enter this as a knowledge domain. It also showed that focusing at that community level, what's happening between the mum and the frontline health providers, and focusing on integrated care is really important. In this example, it wasn't just vaccination. Getting there in the first 24 hours after a baby's born was a chance to educate the mother about warmth, hygiene, danger signs, what to watch for infection in her or the baby, and feeding. It also showed that the type of low-cost technology that Burnett's pioneered with David Anderson's group and the point-of-care tests can make a huge difference in these settings. And it sparked us also to do 2 WHO monographs, which really catapulted my role into immunisation. So I've got just a couple of points to make about implementation, research and delivery science. So really this has come into its own as a knowledge domain just in the last 10 years as it's applied to low and middle income countries. WHO has led this push, but so have many others, particularly in the UK, Northern Europe and the US. And we're really looking at implementation research as this middle step between proving something works and scaling it up to the health system. The Alliance for Health Policy and Systems Research that WHO led has done a great job in pulling together the formal tools and methods for this. They have an excellent website. There's the very first conference on health policy and systems research, global conference, happened only in 2010, so this is relatively recent, but they've been getting better every 2 years since, and there's a few of us who feel that it would be great to have one of the next ones in our neck of the woods, so we're working to that end. But there is now a group of researchers who focus on health systems and policy research. Now, if you're going to research health systems, you could research the governance, the health information systems, using new technology, research new medicines and technologies, which is a lot of what are our end games. You could research the financing, which, such as they do over at NOSL, or Nick Scott or people like that here look at better ways to do financing. But for me, the intersection between our international development work and health systems research really lies in researching service delivery. So how do you organise the services, who provides them, when are they provided, how accessible are they made? And in particular, if we research that intersection between the people who use the services and the frontline providers of the services. So this is where the rest of my talk is focused. There are many tools for implementation research into service delivery and community uptake. I'm going to mention 3 examples. One is a tool that drew on that earlier 1978 paper by Tanahashi called bottleneck analysis, which basically, if you can see in the blue bars, divides coverage into not just a single measure of, say, 80% of children get a vaccine, but coverage actually has a number of different domains, each of which can be measured separately. Domains of whether it's the supplies available, then whether the human resources to provide it are available, whether it's physically accessible, are the clinics close enough, and if you've got a problem in those bottom 3 domains, then you can see you need to fix it by fixing the supply side. But that's not enough to get good coverage. You need people to use it once. You need people to use it continually, especially if they need to come back for a second dose. And then when they're using the service needs to be given them at a suitable quality that it actually makes a difference. All of those things together make up coverage, and analysing where the bottleneck is can actually give you a much more nuanced understanding of what should be scaled up, where to put the attention. This is one of the jobs doing this in Nepal, where I got to work with Alison in a piece of work she was leading on using the bottleneck analysis tool. This tool is still being adopted by UNICEF and others in the latest approaches to implementation research. I wanted to mention realist evaluation. I'm not talking about Myanmar, but we did try this out in our immunisation research activity in Myanmar. realist evaluation now has a 20-year history. The founders of the realist inquiry movement were at a conference in Brisbane just last month, and it has a very strong philosophical and ontological basis, which makes something that looks deceptively simple actually have quite a degree of depth when you put it into practice. And basically, realist evaluation says if you're going to achieve an outcome, you only get to that outcome by looking at the context your work is working in and the mechanism, the how that you worked that way. And it gives a different way of structuring interviews, a different way of structuring a research design, so that you can try and unpack not just whether something's worked or not, but how it works and in which context it works. And the last point about the tools in implementation research is inevitably you end up using mixed methods. We have to do qualitative and quantitative data collection, and it doesn't work if we don't triangulate. So if we don't cross-check something that someone tells us in an interview with direct observation or records review or audit or all three. So you'll see that come out in some of our examples in a moment. So implementation research really fits, particularly looking at service delivery, in this chain where we're not looking at whether something is safe and whether it works. And we're sort of looking at whether it works in a real-world setting, but we're mostly looking at how does it work in a way that can make it possible to scale it up. And this research chain has been picked up by the UK MRC over the last 10 years by requiring any complex evaluation, any complex intervention to have a strong focus on process evaluation embedded in, say, even a randomised controlled trial. But what I'm talking about are these two right-hand ends where we're studying implementation as a primary focus or as a major contributing factor. And this means that we're looking at a different set of questions to what you might look at in a clinical trial, questions of acceptability or feasibility or costs. And the outcome measures we're looking at are things like efficiency and coverage. And this leads us to slightly different types of study types: pragmatic trials or effectiveness trials, observational studies that assess a range of things, including implementation. So Healthy Mothers, Healthy Babies in PNG is a good example of that. Effectiveness trials such, the one I'm not going to mention, but a large trial of point-of-care STI diagnosis in PNG that PNG Institute of Medical Research are leading with New South Wales Uni, that we're involved in. They're studying whether you get reduction in low birth weight through introducing new testing for STIs. We're studying what are the health service implications of that, so how can it be scaled up along the side. And in terms of implementation as a primary focus, we can do implementation studies in the field, but we can also do implementation-oriented evidence synthesis. So I want to tell you a little story about the evidence synthesis that I've been working on for integrated services around integration of other services with immunisation. So this involves something that looks like a systematic review, but instead of doing meta-analysis of quantitative outcome measures, we have to look at qualitative data because we're interested in not whether it worked, but how did it work, what was the mechanism, and what were the contexts that it's worked in. And integration is a critical response to places like PNG where services are fragmented, women find it difficult to get to care, when they do, the care isn't always at the best quality. And what I'm meaning by integrated services is just putting packages of care together. So it's not just malaria, not just TB, but it's a package of care. And sometimes that's through multifunction staff. Often it's by linking across the referral chain, so where the information people present at the rural clinic is transferred up the chain so that they can have a smooth ride up to the hospital if they need it. And this is a global priority. If you look for the word integrate your services or some direction to that effect, you'll find it as point number 2 or 3 in pretty well every global strategy. It certainly features very highly in all of the health measures of the Sustainable Development Goals. So it's something people talk about as if it will magically fix your implementation problems. And immunisation should be the ideal platform to integrate into. It's the only platform in the world that reaches 100 million children regularly every year. So putting your other service for malaria or something into immunisation should be ideal. And it's been done with vitamin A, with distribution of bed nets, other preventive treatment for malaria, for HIV and so on. But it doesn't always work. If you overload staff with too many jobs, quality of care can suffer. If you put, for example, an HIV service into a childhood vaccination service, it's been shown that sometimes mothers don't want to come and immunisation coverage drops. And sometimes when you put everything into one basket, one package, the poorest, who were getting a couple of things trickling down, now don't get anything because it's all in the one basket, so equity can suffer as well. So this is something that needs to be researched rather than just blindly scaled up. And the key thing that I see is the reason why you want to integrate services is because the family that comes to the clinic comes with more than just one problem. They're not just coming with a child with pneumonia, they're coming with a child that needs nutrition care, they're coming with a mother who's possibly got an infection herself, and an integrated service needs to cope with all of that comorbidity in the individual or the family. And that should be the driver of integrated services before any reasons around just making the program more efficient. So that's the reason. We've done some work that grew out of our CPIC studies to do evidence synthesis around hepatitis B vaccine at birth and how important that is to integrate that with other postnatal care services. And it's quite different, as I said, doing a systematic review of service practices rather than a systematic review of trial outcomes, a lot more qualitative data synthesis. But that monograph from 2012 that published by WHO has now led to a couple of other publications, and last year they put it all together into a global guideline for how to do birth dose vaccination in an integrated fashion. Other work that I do with the WHO immunisation community are listed there, but I'm going to skip over them, except to mention maybe the control temperature chain group is looking at how we can take vaccines outside of the fridge for up to 4 days right at the end of the chain. We can do it with human papillomavirus vaccine for school campaigns. We can do it with oral cholera, which we need in places like Yemen and so on right now. We can do it with hepatitis B vaccine. We can do it with tetanus toxoid vaccine. So we're exploring that implementation. So this is my systematic literature review of integrating immunisation and other services, where the Cochrane Effective Practice and Organisation of Care group have got a very helpful approach to how do you synthesise not trial outcome data but practices data. And there's a node of Cochrane here at the Alfred and another companion node over in Norway, and it's those two groups that we work with. And after screening 14,000 titles with the wonderful Jess Davis, who's not here but was a great help through this process, we've come up with 24 studies with reasonable controls and a whole lot of studies with qualitative data. And we've been able to extract from those studies what are the actual modes that you do integration. Is it just extra services provided by the staff, so you make them into multifunction staff, or they just do extra counselling, not just an extra service? So maybe they talk about family planning while they're doing vaccination, or maybe they actually give out a bed net while they're doing vaccination. Or do you co-locate the services? Some other examples have shown where you put the second service, such as family planning, next to the immunisation clinic, have it open at the same time. In Port Moresby, in the busiest vaccination clinic in the busiest town in PNG, you get vaccinated on a Thursday and family planning is only available on a Tuesdays. So these are sort of pretty basic things that is what is meant by co-location. And really what we've found is that when you integrate, another service like malaria or HIV generally benefits. It gives them a boost in coverage. Although there's a few things like bed nets clearly go out better through antenatal care distribution than through immunisation clinic distribution. And usually immunisation doesn't get harmed. Although there's one example I've mentioned already about HIV putting mothers off because they're scared. And it's pretty clear that co-location looks like it works better than multifunction staff, and that matching routine preventive works better than mixing routine with clinical. So one of the constantly repeated refrains in the immunisation community is if we can, when a sick child comes into the clinic, we need to get systems in place where they check the vaccination status of the child and bring their vaccinations up to date. But it just doesn't seem to work because of the way health workers behave in these resource-constrained settings. They're dealing with a sick child and stopping, going to get the nurse who's got the key to the fridge where the vaccines are to come and vaccinate the child is just not a priority. But putting together growth monitoring and nutrition counselling, which is a preventive service, together with vaccination actually gives a boost to both. So we can do better at focusing where the gains are most likely. And the other thing that was clear in all of these studies is that nobody asked the client what they want. There are many publications at the moment around the human papillomavirus scale-up about whether families will accept this new vaccine. And this is a vaccine that deals with cervical cancer, which is spread by sex, so it's a vaccine that's sort of bound up with sex and sex of young women or girls. And so people are worried that there's community resistance. So there's been hundreds and hundreds of community acceptance studies asking questions around, would you accept HPV vaccination for your daughters? And they're great studies, but the one question that none of them seem to ask is how would you like the services to be organised so that you can better access the vaccine for your daughters? So those service delivery questions aren't part of the standard set, and we need to do a better job of asking the client what they want. So example number 2, this is us trying to do a better job. So I think most people in the room know about Healthy Mothers, Healthy Babies up in Papua New Guinea, on the East New Britain province, you can see in the map up there. And we're following 700 mother-baby pairs from their first antenatal visit and catching them at certain time points. We're making great progress. Is Liz here? Yeah, there she is. Thanks to Liz Peach, who's the research program manager up there. Michelle Schooler was the research program manager up there. We're nearly finished catching all of these mums that we can at the delivery point and making good progress at the later time points as well. And I'm not going to go into all the details of this study, but I want you to notice that when we look at these mums, we're taking biological samples, and most of you are interested in how much malaria is there, what type of malaria is it, is there TB, what sort of STIs are we seeing, those sorts of questions, which is fair enough. We're looking at the growth of both the mother and the baby, their height, weight, etc. But we're also doing interviews around their background, their experience of illness, their planning of future health service work. So we can actually say, how do you plan to access immunisation services? And then we're catching them afterwards so we can see how the plans worked out. And if they didn't, what actually went on. And we're also doing the job that others haven't, asking them for ideas about how they prefer services to be organised. And if you think about this from an implementation research perspective, you can notice that a lot of these questions will give us information about the comorbidity. So how many of these mums have got more than one thing going on that really needs an integrated service to respond to it? And we're also asking for the client's preferences around how services could be better set up. And we found there is a lot of comorbidity, many STIs, some malaria, some mums with serious cough that needs investigation, and a lot of anaemia and probably a significant amount of maternal malnutrition that overlays this, certainly a lot of child malnutrition that overlays their infections. So basically these mums come in, have their baby, but no one has really been addressing the sexually transmitted infection or the nutritional problem that the mum has that then affects the weight of the baby. So there's a clear case for integrated care. And when you ask mums, what would you like? They say, at different points, we'd like to actually get advice on family planning when we come back after childbirth. We'd like to actually get care for our own illness. and some disease prevention advice, as you can see in the top. None of those things are really happening at the moment. But when you think of the mum who's been sitting there for 4 hours on that wooden bench outside the clinic for 8 minutes of consultation, that's not really integrated care. What's in the current policy in PNG? To do all of those things. Everything should be done. That's the nature of PNG policies. They're aspirational and unachievable. What's current practice? You get vitamin A and deworming of the child in a well-run immunisation clinic. Otherwise, you just get immunisation. And the mum who's still got lingering illness, lingering nutrition problems, gets nothing. And we were able to show this in the last example, and I'm racing towards the end, 8 minutes, you can make it, where we looked at the flip side. Instead of looking at the mums, we've gone and looked at the clinics where these services are being provided. And to do this, we used a pretty standard implementation research approach, which mixed interviews, and you can see down the bottom, audit and observation, and and examined all the way down the chain, from national managers through the senior clinicians, nursing officers, the frontline community health workers. We've also had discussions, again, with groups of families who are attending immunisation services. And we did it in general paediatric outpatients where vaccination should be happening. We did it in the static clinics, in the fixed site, and we did it by going out and watching how a mobile clinic worked. So we used the mixed methods that I've mentioned already. We did some triangulation. And what's interesting in the triangulation is that you hear one thing in interview, but you then see something totally different when you sit in the back corner and observe the clinic in action. And the construction of our interview guides drew on realist evaluation methods. So we were trying to unpack, when people said something, with follow-up questions, what was the mechanism by which what you were talking about would actually work? Does it work only in some contexts, or is it going to work in all contexts? And so very early findings on this health services study, really that the critical time, the time when a baby or a mother is most likely to die, is the first 3 days after childbirth. And there's good models for doing routine postnatal care in that first week. The PNG newborn care policy says every child in the country will have a visit on day 1, day 3 and day 7 after childbirth. We found no evidence that those routine visits or routine checkups are happening almost anywhere. Basically, the only way a mum and baby after childbirth gets a routine check is if they happen to have their baby in the hospital and somebody does it before they go home. So there is a big gap in a service area that can make a huge difference to saving maternal and newborn lives, which was the key finding. We found that there is a big gap in planning at immunisation clinics where they'll go out to a new site but not know how many children they're expecting to see. They'll be looking at their district and planning where to go, but again, not knowing where the children exactly are. So the gap relates to that interface between the community and the frontline providers, understanding who their catchment is, where their catchment is living, and maybe the next level is understanding what their catchment, what the families they serve would like. When we observed, we found vaccinations done pretty well and done quite safely, but we saw very little communication between the staff and the family. So there is this opportunity during the immunisation visit for extra counselling on feeding, how are things going, is the child sick, and not much of that is happening. There's an obligation in the vaccination visit to make sure that the mum knows what was just done to their child and when to come back. Again, that is not happening to a significant degree. There's a little bit of integrated care, but it's not hitting the points that mothers actually said that they would prefer. When we asked about how could things change in the future of staff, health staff say yes, putting family planning in would be a good idea. So would health education, so would work on STIs. So the staff recognise it. They know this is important, but they don't do it. So it's a classic example of the no-do gap that implementation research can help fill. So I hope our next activity in PNG is a study on how can we actually implement integrated care. Let's work out the mechanisms of success, the context that determine whether it's successful or not, and of course one on postnatal care. So at the end of the sort of thinking through the high-level systematic review on integrating immunisation services globally, and looking at the 2 Healthy Mothers, Healthy Babies studies that we've got some tentative conclusions. We need to accelerate postnatal care. Integrated services must be pursued, but they must be tested as they're pursued to make sure that putting a family planning together with immunisation, for example, doesn't, in this particular context, mean fathers or mothers-in-law are reluctant to have that baby go because they're worried about the other stuff that might be getting said to the mum when she takes the child. We need to test for acceptability and engagement and research that no-do gap. Researching the no-do gap means really getting into the motivations, the pressures on health staff, working out why it is that they don't do something that they know is actually a good plan. And there are questions for any program that any of our international health development staff are working on. The first question is, if you're working on a development activity, what are the implementation research questions that you can help to unpack? What are the tools that can be used? And what are the mechanisms for integrated care that could be explored, whether that's TB, malaria, HIV, or any of the others. So, I'm going to finish. If you're sort of feeling swamped, the rising floodwaters, such as this bridge just outside of Shigatse, which we're contemplating whether to cross or not, you can't see the date, but it was 2000 was the year. And at the other end of the bridge is the international health development that we want to do. And at this end of the bridge is what we know, what our operational and basic research has shown us about what works and what's safe. I think one part of the bridge is implementation research and delivery science, and that's what I'm passionate about. So it takes a village to raise awareness or raise a barn or raise a professional career. Here's a couple of my villages. The one in Papua New Guinea, which has got lots of Burnett staff in the principal HMHB investigators list up there that you can see. Put your hand up if you can see your name. The field research team and the generous supporters. This is an unusual program, as people like Paul, Tracy, Steph and the others who make it happen that we can get private donors supporting research in PNG, not just Australian donors, but PNG donors as well. I think that's a pretty big achievement. And of course the research team there. And I'd like to thank the many families and health workers in PNG, Nepal, Tibet, other places I've been privileged to work alongside. Brendan for his, and the other leadership, thank you for the award. It's really nice to have development recognised in the Fenner Award, and for your passion for PNG and for pursuing development alongside research. The international development staff, past and present, so many names I could mention, so I've left them all off. Led by Robert, I've mentioned Tony already. The Women's and Children's Health team, who I've spent a lot of time with over the last little while. There's a few photos there. Peter Deutschmann got me into this game at the beginning and has been the person who's got me into some of the most interesting jobs, like the immunisation work with WHO. And I really appreciate, Peter, your guidance and mentorship over the years. Mike has played a similar role, gave me a job, even though he's not here today. And a couple of mentors in WHO who taught me a lot about how to get the world vaccinated. My long-suffering research supervisors, James, Bev, and thank you to the Doherty for providing, Sarah's up there. My desk at the Doherty is a sort of studio's haven of peace where I can sit and work. It's a place of sparkling intellects and an endless supply of dark chocolate. And my parents took me to PNG in the 1960s. My kids who managed to thrive at altitude, you can see the 6th birthday party at Everest Base Camp in the bottom right-hand corner. And Alison, who's been my partner in crime in work. It's not often you get to work with your partner, but it's a joy, and in life.